Thank you very much to all of those who have joined us on this webinar. My name is Andrew Lacy. I'm the founder and CEO of the company, and I'm joined for the next hour and a half with, by Dr. Sean London, who's one of our very experienced members of our radiology team, who's heading up the practice here. What you can expect in the next during this webinar is a very brief overview from me about what's in the scan and what to expect. The most important thing here is the time that we have with Dr. Sean London to actually go through a scan. As a radiologist would look at the images of someone who's come into one of our clinics. So he'll go through each of the parts of the body from head to tail and talk about what we can see, what we can't see, what are some of the common findings. And hopefully that gives you a pretty thorough understanding about just how comprehensive some of these scans can be. And then towards the end, I will come back together with Dr. London and we'll answer any questions that people might have. We'll bring people up to the stage to ask them. So what is the Prenuvo scan in a nutshell? It's around 45-minute scan. You spend about 1 hour inside the machine. There's no harmful radiation or contrast. So this is a scan that's intended to be taken ideally annually. It provides very, very comprehensive coverage for cancer and chronic disease, and ideally catching many of those conditions early when either the treatment is very simple or possibly even just lifestyle intervention and change to diet, health, exercise, and so on. We operate our own clinics around the US. I'll describe where they are in a second, but we control the quality end to end. These scans are designed for longitudinal health tracking. So an individual scan is a fantastic insight into your body at a point in time, but these scans become even more powerful when they're done longitudinally. And the goal here really is to put your own health in your own hands, to really be sort of the CEO of your own health, to give you agency so that if there are things that you need to follow up, that you have all the information available at your fingertips to be able to do that most effectively. There's not a lot of areas that we can't see in the body. Obviously, we are assessing 33 organs for hundreds of conditions. We have a very good track record of diagnosing cancers at stage 1 when they're still localized to the organ of origin. We are looking for other killers like aneurysms that we can get in the brain and other parts of the body. We're able to do a complete assessment for metabolic disorders like fatty liver. We look at both the male and female reproductive systems. Most importantly, we're also looking at completely the spine in these exams, and there's a whole bunch of other conditions. And this will become apparent as Dr. London goes through the exam. On average, we're alerting 1 in 20 patients to a potentially life-saving diagnosis. About 1 in 3 patients make significant and lasting changes to the way that they're managing their health based on what they see in the scan. And about 90+% of people feel tremendous peace of mind, like some of the folks that we saw in that video. As I mentioned, we operate our own clinics, and these clinics are designed, frankly, to help reduce health anxiety. It can be sort of a bit nerve-wracking to go into a medical facility for many people, and we wanted to create an environment that felt warm and comforting, staffed with folks that take their time to take patients through this exam. And you'll see inside the clinics, you can watch television while you're doing a scan. The team are on hand to really help people get through rather than rush people through. And we're really excited now that we've figured out the knack of getting people through a really comprehensive exam in 45 minutes. And as a result, we're able to provide such tremendous insights for people's health. Those insights come in the form of an app and a medical report. The app gives you access to every image that we take. You're able to scroll through those, zoom in and out, really get to understand your body in its most sort of comprehensive and unique way. It's something that if you've done imaging before, it's really hard to get the images. Sometimes you have to send faxes in and get CDs. We want to make that available to folks directly in the app and on our website. And then there's a medical report that we also make available for your medical practitioners. We are currently located in 17 locations. There are others that we're in the process of launching over the coming months. So hopefully there's a clinic that's within an easy drive or a short flight from where you happen to be located. Before I hand over to Dr. London, I just wanted to sort of leave everyone on the webinar with, I guess, kind of a few thoughts that were running through my head as I got my 5th Prenuvo scan a couple of months ago. The first is, this might sound obvious, but knowledge about your health really should be empowering. I have to be honest, even 5 scans in, I feel a little anxious when I sort of go in for that scan. And I tell myself, like I tell other patients, that that anxiety is not about me. It's really a function of the health system that we're all a part of. We have a healthcare system that diagnoses disease late. And if every disease diagnosis you ever hear about from family, friends, colleagues, yourself is late, not a lot of people are always very excited to learn things about their health. That's got nothing to do with me. That's got nothing to do with you. That's got everything to do with the system that we're a part of. And to be honest, that's, we know we will have succeeded when we have taken away the stigma from the definition of disease so that people are very excited and empowered to learn as much as possible about their bodies so they can live both a long and very healthy life. The second here is there's a lot of noise about Prenuvo. We've been covered a lot by media in the over the last year or two. There's been a lot of famous people that have come in and have sworn by the exams. And then there's been physicians that have talked about it, perhaps, without a lot of direct knowledge about what it is that we're doing. And that's why we put these webinars on, and we frequently invite those people that talk, perhaps without direct knowledge about whole body screening that we're doing at Prenuvo, to really have them experience to firsthand what it is that we're doing. So I just want to contextualize that information space. There's a lot of people talking, but not a lot of people talking that actually have gone through the exam or have really sat down and spoken with our radiologists. And in fact, one of the things that we're most proud about at Prenuvo is we now have 60 or so reading radiologists with us. And many of those are people that are, graduated from Ivy League institutions. These are radiologists that could work almost anywhere. And they have seen the power of what we're doing and have chosen to work with the company. And I think that the choice that they've made speaks volumes about the service that we're providing and the excitement about this space and what it can mean for health more broadly. The third, I think, personal challenge really is around prioritizing proactive measures. My fifth Prenuvo scan, I was late by 2 months. It's pretty easy for a lot of things to get in the way of preventative health. If we don't feel sick, it's pretty easy to kind of put things off. And I would encourage you to just kind of bear that in mind, and that eventually, if you want to live a life with sort of driven by proactive healthcare and preventive medicine, then you really need to find time to do these types of tests. And on that note, I'm going to hand over to Dr. Sean London to take us through a journey inside the human body.
Before we begin, I just wanted to make a couple comments about our exam. We have three different exam types or protocols. The one I'm going to go through is our most comprehensive whole body exam. And the concept here is that we're trying to cover as much of the body in the shortest amount of time and still provide the clinically relevant information that could potentially be actionable and life-altering. That said, we don't necessarily acquire all the images that you would in a dedicated exam. So we obtain the most high yield sequences in each body section to get the most clinically relevant information. And so here you can see these 4 different panels showing the brain up here. And then on this right side, this is called diffusion weighted imaging. This is one of the image sets that really sets us apart here. And it's a really valuable sequence to have, particularly in a screening setting when we don't have any contrast on board. And the concept behind the diffusion weighted imaging is we're looking at the movement of water molecules within tissues. And generally they're moving around freely, but then anytime that they become restricted in their movement, they're going to show up on this set of images as areas of darkness. Now, that doesn't mean that all these dark areas that we're looking at here are pathologic or bad. Some things are meant to show restricted. This is all physiologic distribution here. And this is one of the first image sets that I look at when I approach these exams. I like to get a lay of the land, and this gives me a nice overview of the body. And so I can go target it after that. So if I did see something abnormal on here that really showed up, then I would go to my anatomic sets of images and characterize it further. So that said, I'm going to start up in the brain. Here, we're looking at the brain, and this is called axial orientation. And so I'm starting at the inferior portion by the skull base. And just to orient everybody, in the axial orientation, it's actually flipped, the image. So this is your right eye, and this is the left eye here. And so as I start at the inferior portion, This is the most inferior brain tissue called the cerebellum. This looks very normal to me. This has normal volume, no masses, no signal alteration. And then as I come up higher, I get into the brainstem right here. This is what's connecting the brain to the spinal cord, and this also looks normal. And then I go up higher. This is the higher functioning brain tissue. Here's the right side, and here's the left side. And this is all very normal signal. I don't see any signs of masses, no white spots or white matter disease. The other thing that I always assess when I look at these visually is looking at overall brain volume. And the way that I can do that visually is looking at the center portion of the brain here and also on the periphery out here. So this black butterfly looking structure, this is called the ventricles. This is where the fluid is made that bathes our brain and spinal cord. So if I saw this enlarged, this is actually normal size. This looks great. But if this was enlarged and there was no obstructing mass or process that's obstructing it, that tells me that the brain tissue centrally is shrinking. This is a closed system, so something has to occupy the space. So if the brain tissue here is shrinking, it's going to start expanding those ventricles, and that's an indication that we are losing brain volume here. And then also I look at the periphery, these black grooves between the brain tissue called the sulci. If the cortical tissue, that's what this part of the brain is called, if this is starting to lose volume, we're going to see widened spaces here and more black fluid right here. So that's also another sign that we can pick up on and see signs of volume loss. Now, overall assessment of this brain, this looks like a very healthy, normal-looking brain visually, no signs of volume loss, and no pathology going on. As I also on this set of images, I take the opportunity to look at the sinuses. These are the air-filled regions in our forehead and face. Now, they're filled with air, and air on MRI looks black. So anteriorly here, at the top of the image here, you can see this black region within the bone. This is the forehead. These are the frontal sinuses, and this is how they should look. Whenever we get inflammation or sinusitis, what we're going to start seeing is tissue thickening that surrounds along the walls that surrounds the air. And so right here, these are called the ethmoid sinuses. These are between the eyes. You can see this white line starting to get a little bit thick right here, and this is a sign of very mild inflammation of the tissue. This is really common, just being exposed to the environment. Allergies, common head colds can cause this, and it's generally a transient process that doesn't really require any treatment. As I keep going down, we see more sinuses behind the eyes, and these are air-filled right here. These look nice. And then I keep going further down, and we can see a little bit of more tissue thickening back here. And this is also some mild inflammation within the sinuses. These are called the maxillary sinuses within the cheeks, but otherwise I don't see anything else going on. I also take the opportunity here to look behind the nose. This is called the nasopharynx. This is where we get communication with the middle ear right here through our eustachian tube. And what I'm looking for here is any kind of asymmetric soft tissue that could be a sign of a cancer, a nasopharyngeal cancer. This looks very symmetric and normal, so nothing concerning here. As I go back to a smaller set here. The other thing, we also obtain images of the brain in the sagittal plane, which is looking at the brain from the side to side. So if I scroll this way, I'm looking at the right side, and if I scroll this way, I'm looking at the left side. What I like about this set of images is it gives me a very nice view of the brain stem, the spinal cord, which look normal in this case. And I can also see the pituitary gland. This is like the hormone control center. This is a normal looking gland. I will say that with any screening test, there are limitations. We're not going to be able to see certain details that may be picked up with dedicated contrast enhanced exams. Just depends on the clinical indication. For an example, in the pituitary gland, if there's a tiny nodule, generally called a microadenoma, they can be functional and secrete too much hormone. We have a difficult time detecting those on this set of exam because of the overall size, and it generally does need contrast in order to get it to stand out within the background tissue. But otherwise, this looks like a normal gland, and I don't see any concerning findings there. I also take the opportunity to look at the eyes again right here, and this looks normal. This is the lens of the eye, so there's nothing concerning there. And I go back and I look at the other eye, and it also looks normal as well right here. And then I also do look at the major veins within the brain area. These are called the sinuses, the dural sinuses. This is how they should look. Sometimes for different reasons, whether it's medications or genetics or other pathologic processes, we can develop blood clots within these veins, and it would show up as bright white signal or color, and I don't see any of that here. So these all look normal as well. And then finally, within the brain too, we look at the major arteries feeding the brain. This is a 3D reconstruction of the image set that we obtain of the vessels. In general, this actually looks like we administered contrast or IV dye, and we did not. We use a certain technique that actually takes advantage of the way that the blood flows. And what we're doing is we're just highlighting the major arteries feeding the brain here. These are the cerebral arteries. So these are on the big ones on each side of the image here, the right side and the left side. These are coming up from the neck, and then they go all the way up into the brain area, and then they start to split off to feed the various portions of the brain. The main thing that I'm looking for here is, one, to make sure that they're open, and they are here. They're nice and white, and I don't see any signs of narrowing. But really what I'm looking for are brain aneurysms. Brain aneurysms are areas of focal wall weakening that pouch out. And the issue with brain aneurysms is particularly when they get large in size, is that they can rupture. So we do like to detect these as early as possible and monitor. I would say the vast majority of brain aneurysms we do find are pretty small and can be surveilled safely depending on other risk factors. But it's always a good idea, if we do find one, discuss it with a specialist to make sure that the management is appropriate. Here, I don't see any outpouchings to indicate signs of an aneurysm, so these look good. Wide open vessels and no aneurysm. The next thing I do is I go and look at the neck, and that is going to be on this set of images over here. So starting from the top, as I come down here, again, this is brain tissue. As I come further down, I look at all the major salivary glands. So we have paired structures by our ears called the parotid glands. So here's the left one right here by the left ear. Here's the right one by the right ear. And these look symmetric and normal, and I don't see any concerning masses in there. And then as I come down further, now I'm in the mouth region. This is actually the tongue. It's a bit obscured by some dental hardware here. So MRI doesn't like metal. It creates an artifact, so I can't see this region within the mouth. But fortunately, the dentist is also very good at screening for oral cancers. So I always encourage people to do routine dental care, as that is also an opportunity to catch any kind of early cancers within the mouth. But I don't see anything concerning in this region. And same thing under the tongue right here. There's a bit of artifact here from that dental hardware, but I can see some of the glands here, the sublingual glands, and those look symmetric and normal. Back here is the back of the throat. These are the tonsils that we see in the back of our throat when we open our mouth looking in the mirror, and these look normal. And then I come further down and I see more glands under our jaw. This is the submandibular gland on the right, and here's the one on the left, also symmetric and normal, nothing concerning. As I come further down, I'm looking at the neck soft tissues, looking for any abnormally enlarged lymph nodes. I don't see any. These all look like physiologic lymph nodes that we're supposed to have. Here's an example of a normal appearing lymph node right here. It kind of looks like a bean or a curved backward C there. That's how they should look. Our lymph nodes generally respond and can get enlarged and at times of infection, but can also be pathologic and become enlarged due to cancers as well. So that's why we look at them throughout the whole body. I don't see anything concerning here. And then as I'm coming down here, here's the airway. These are the vocal cords, symmetric and smooth, no growths on them. And then I get to the base of the neck. This is the windpipe, the trachea, this black circle. And then here's the thyroid gland overlying it. Now, I can see the thyroid gland pretty well here. It looks normal size, has a nice homogeneous signal. I don't see any signs of a nodule or a mass, but I will say that MRI is not the best test to pick up for thyroid nodules. That is, thyroid ultrasound is much more sensitive at detecting nodules, particularly when they have similar soft tissue structure to the background gland. They just don't stand out that well here. Obviously, if we do see one, we comment on them. But if you have a known thyroid nodule, it's best to be followed with an ultrasound. So nothing detected here. Next, we travel into the chest. So again, as I come down, this is the right side of the image. This is the left side of the image. And as I'm coming down, here we see the right lung right here. It's nice and black. And here we see the left lung nice and black. They're filled with air. These white lines are the vessels that are coursing through the lung tissue. These are normal. What I'm looking for here are any solid nodules or masses or signs of infection, and it generally would show up as a brighter color or signal. And I don't see anything like that in either lung, so both of these look clear. In general, too, MRI is not as sensitive at detecting lung nodules as CT scans are. CT is the best imaging test to look at the lungs, looking for nodules. But most of the time, if there's a concerning nodule, it generally, if it's manifesting within the body, I'm going to pick it up on these sets of images. The small little benign inflammatory nodules or calcified nodules don't really show up on these tests, but that's okay. Those are statistically benign and generally don't really require much surveillance. But here, both lungs look clear. The other thing I look for is any abnormal fluid accumulation around the lungs. I don't see any abnormal fluid. Those are called pleural effusions. They would show up as bright white signal surrounding the lung tissue. And then I go and look centrally within the chest. This is the heart right here. Now, the heart is always in motion, and MRI does not like motion. This is why we always ask people to hold very still and follow instruction. And with the heart beating, it creates a blurry image. So that being said, I can't see the heart vessels well. And this test is really not tailored to look at the heart in detail. There are other ways to do that if needed. But at this time, our heart assessment is limited on this scan. I do look at the size, and the size is normal. The other thing I do look at is the aorta, and that comes out of the heart right here, and it goes up like a cane right here, and then it swings all the way down into the abdomen. And what I'm looking for is the size to see if there's any signs of abnormal dilatation or an aneurysm, and I don't see that here, so we do measure it and make sure that it's normal size. And then just like I did in the neck, I'm looking for any abnormal lymph nodes that are centrally within the chest, and I don't see any abnormal lymph nodes. And I also look in the axillary regions, the armpits. Here's the left side and the right side, and I don't see any abnormal lymph nodes here. Generally, just because of the location here, people are able to feel any enlarged lymph nodes, but I don't see any here in this patient. And then we do look at the chest wall. In this case, is a female, has breast tissue. This test is not tailored like a dedicated breast MRI is. So I encourage people to continue to do standard breast screening, which may be mammography, ultrasound, and breast MRI with contrast, if indicated. This does not replace that. I still look to see if there's any nodules or masses. One limitation that we have with MRI is that we cannot see microcalcifications, and that is something that we're constantly looking for in breast tissue using mammograms, the X-rays. Those are signs of early stage breast cancer called DCIS. Those are the cells that are rapidly proliferating, and then they die off into the ducts and they calcify, and so that's how we find them using X-ray mammograms. Here, though, the tissue looks symmetric, and I don't see any concerning findings in either breast. Then we go down into the abdomen here, and I start to look at all the organs of the abdomen. And on the right side, the largest organ in our abdomen here is the liver. This is it right here as I'm outlining it. I'm looking at its morphology, its structure. It has a nice smooth contour, so that's normal. I don't see any signs of cirrhosis or chronic liver disease. I don't see any masses in here, and I don't even see any cysts. Cysts are so common in our bodies. We see them, they can happen anywhere. The liver is a common place to see them, as well as the kidneys and pancreas and spleen, but I don't see any here. Now, with MRI, we can utilize the other images we acquire and look at the same organs and get different information about it. So in the top right corners, you'll see two sets of images here. This one right here, this is the one that we use to look for liver fat accumulation. And the way that we can assess that is if there's too much fat buildup in the liver, it's going to start decreasing or diminish signal. The color will get darker and darker and darker. If you look back here, this is the spine, and the spine is filled with bone marrow, which is very fatty. And you can see how black it is, and that's what happens when there's a fat accumulation. It gets really dark in color. So if you saw this in the liver, that would be a very severe case of fatty liver. We don't see that here though. And then I go to this image set and I'm looking at iron accumulation. Our liver normally stores iron, but it can accumulate too much, generally due to genetic causes, but can be secondary to blood transfusions. And what I'm looking for here is the color of the liver, the signal intensity to get darker in color. When I see too much iron, it almost becomes black, darker than the spleen over here. So this looks normal. I don't see any abnormal iron accumulation here. The reason I care about either one of these, or that we care about either one of these, is that if there is either one of these processes long-standing, it can predispose to chronic liver disease, liver failure, and cancers within the liver. The most common one we see is fatty liver, just generally related to our culture, drinking, bad diets. But the good thing is that it's modifiable and reversible most of the time. So knowing about this early is a good thing to know, and then we can follow up and see if we have any change within the liver just based off lifestyle modifications. The next thing I do is I look at the gallbladder, the bile ducts, and the pancreas. And as I come down here, this set of images is designed to highlight fluid, which shows up as white signal or color. And so here, this is the gallbladder that lives under the liver right here, and it's nice and white. The most common thing that I see in here are gallstones. They look like black rocks. They're really common. Many of us walk around with it and we don't even know. If they obstruct the gallbladder, the flow of the bile outside, we can get inflammation and pain. And that's generally when people find out that they have them. And the solution for that is generally just removal of the gallbladder. But in this case, I don't see any signs of gallstones. I don't see a mass or any abnormal wall thickening or inflammation, so this looks normal. And then I look at the bile ducts right here coming down, and this is transporting the bile from the liver and the gallbladder down into the intestine to help digest fatty foods. I don't see anything obstructing. This is within normal limits for size. So no stones in here and no mass within the bile duct. And then I can also look at the pancreatic duct right here, and it courses throughout the pancreas right there, and it's nice and thin, not dilated, has a nice smooth contour, and I don't see any abrupt cutoffs. What I'm looking for, the earliest sign of pancreatic cancer that I've seen on these types of exams is an abrupt cutoff of the duct and then dilatation proximal to that or distal. And that is generally due to a tumor growing within the duct. So any kind of caliber change where we can't follow this fully, we generally recommend further workup to make sure that there's actually nothing obstructing that duct. This one looks normal and there's nothing concerning here. And then I look at the pancreas on multiple image sets to make sure that it has normal signal and that there's no subtle masses in here. I didn't see any, but just to show you what it looks like on the main sequence that we look at right here, this is the pancreatic head, this is the neck, body, and tail, and it goes across our whole upper abdomen. And this all looks very normal, so no signs of pancreatic mass or even concerning cysts in here. Then I keep moving on and I look at the stomach right here. There's a little bit of fluid in here, but that's normal. The wall looks normal thickness, so no signs of masses. Here in the left upper side of our abdomen, this is the spleen. This is normal size, no signs of a concerning mass. And then I keep going and I look at the adrenal glands, which live above the kidneys. Here's the right one right here. It looks like a little V shape or Y shape upside down. And then here is the left one right here, and these also look normal. If I did see a nodule or mass within the adrenal gland, I'd say the vast majority of the time I can actually characterize them. And using our other image sets that I just showed, the one with the fatty liver and iron, because vast majority of the time, these nodules are actually something called benign adenomas. They're not malignancies, but what they do is they can secrete too much hormone if they're functional. The way that we can characterize them is look at that other image set, and if the nodular mass gets darker in signal intensity, that's an indication that it contains fat, which is consistent with an adenoma. So that's how we can characterize those on this test. And then I go further down and I look at the kidneys. This is the right kidney right here, and this is the left kidney right here. What I'm looking for are any kind of concerning masses or complex cysts, and I don't see any. Here, I do see a very simple appearing small cyst, this bright white circle right there. These are so common. I see these every day. We really don't have to do anything with these. And we just reassess them on the next scan to see if they have any growth. They can grow, but it doesn't mean that they're transforming into a cancer. The features that I'm looking for to determine if it has any concern for a malignancy or cancer would be any kind of soft tissue components within the cyst, because these are just fluid filled. But as soon as I see soft tissue in there, I generally send them for further workup because that's a concerning sign that it's a concerning sign that it's a cancer. The next thing I do is I look at the bowel, so the colon. That's right over here, this black area, and it actually goes all the way up, goes all the way across the abdomen and down. And I can show you on a different image set if I go over here. But one thing I would definitely emphasize to anybody who's going through this exam is that this is really not designed to assess the colon. We can't see polyps, and that's really what we want to be catching. The best way to detect that is scope, so a colonoscopy, and they can go in with the camera. If there are any polyps, they remove them then, and then they look under the microscope to see if there are any kind of pre-malignant or just benign polyps, and go from there. There are other non-invasive tests that are out there that can be explored as well, but colonoscopy is certainly the gold standard for colon screening right now. But I still do take a look to make sure that there's nothing concerning. And what I'm looking for are any kind of constricting masses, wall thickening, or signs of inflammation, and I don't see any of that here. This all looks very normal coming across over there, and then it swings all the way down this way and out. So this has stool content in it, which is normal, this black stuff or this gray stuff, but I don't see anything concerning in here. The next thing is we go and we look at the pelvic structures. So for females, we obtain a sagittal image set, so from left to right and right to left, side to side, looking at the bladder right here. This is the bladder distended with fluid. It's nice and white and thin walled, so I don't see anything concerning in there. What's really nice about MRI, again, is that we're taking advantage of the different tissues, and that creates contrast for us intrinsically. And so I can see the wall really nicely just due to the fact that it's distended with fluid. So I don't have to give any IV dye to actually see distinguish between the inside of the bladder and the wall. So this looks normal, no masses. Just behind the bladder right here is the uterus. This is a normal looking uterus for a postmenopausal female. It's a bit smaller. They tend to get smaller in size in the postmenopausal period. And what I'm also looking for is the endometrium, this white stripe right here. This is how I want it to look. I don't want it to be too thick. For premenopause females, the endometrial stripe right here is going to change in thickness depending on the stage of the menstrual cycle. It tends to get thicker throughout the cycle, and then at the end of the cycle, it starts to shed off and become thin again. But in postmenopause, that doesn't happen anymore. So if I saw this too thick, I start to worry about potential endometrial hyperplasia or cancers. It's kind of a continuum. There are other causes of it, hormone replacement therapy. If anybody's on hormone replacement therapy and you're undergoing surveillance of this with ultrasound, the reason is they just want to make sure it doesn't get too thick. What you will see just behind the uterus is this sizable mass right here, and this is actually coming from the right ovary. Now on this image set, it's bright in signal, and so what I'm thinking right now is like, is this fluid or is this blood or is this fat? And I can actually distinguish what that is by looking at my other image sets. And so over here, this is a fat saturation image set. And so anything with fat is going to get really dark in color. And on the far right is my fat highlighting sequence. It's called a water sat sequence. And all it does is anything bright white is going to highlight the fat. So based on all of this image set here, I can tell this is a fat-containing ovarian lesion. This is consistent with a dermoid cyst or a teratoma, and these are benign actually. But just because they're benign doesn't mean that we shouldn't watch them or they can't cause problems. When they get really large in size, they can act as a pedicle and actually cause torsion of the ovary, which can be very painful and is actually a surgical emergency. There's very low likelihood that this would transform into something malignant, but it should be surveilled. And if there's anything concerning in terms of growth or any other features, they generally get removed. So this is, we've characterized this one here. And then just in comparison, this is what the other contralateral left ovary looks like. This is what the right ovary should look like. It's nice and small, and they tend to shrink down in size in postmenopause, even to the size of a raisin. This one is small, but I don't see anything concerning going on in the left ovary. I cannot see the fallopian tubes unless they're pathologic, unless they're abnormally dilated or there's a cancer coming from them. So the fallopian tubes are generally not visible to us on imaging. And then finally, we head over to the spine and we obtain a full image set of the spine right here. And let me blow this up. So this is how the spine is kind of broken down. We have right here, these are the bones that make up the spine. These are called the vertebral bodies. The squares are called the vertebral bodies. And in between the squares, these bones are the discs, the intervertebral discs. These are the cushions. And generally what happens is with degenerative process is, and just normal wear and tear through our lives, is we get pressure on these discs. And with that pressure, we start to get bulging of the disc backwards. So we can see a little bit of a bulge at this level. At 5-6 is a very common level. And you can see that it's pushing backwards. This white stuff right here is the fluid that bathes the spinal cord, which is right here. And so we can see that the disc bulge is actually pushing on the fluid, but I don't see it pushing on the cord, which is good. But this is a good thing to know about so that we could do any lifestyle modifications to prevent further degenerative change. And generally too, it's really important to correlate any of these findings with any actual symptoms. It's so common for us to have wear and tear and not have any symptoms. In that case, there's really nothing actionable other than just trying to modify our lifestyles to prevent further degeneration. Overall, this is a very typical good-looking spine, actually for 59 years old. The thoracic spine almost looks completely normal, with the exception of some degenerative change within the disc itself called disc desiccation. But I don't see any signs of disc bulging, anything compressing the cord, or anything narrowing the foramina where the nerves exit the spinal cord. And then kind of the same thing in the lumbar spine region. This is the lower region of the spine. There's some disc bulge pushing on the fluid, but there's nothing pinching the nerves that I would think would be symptomatic. So overall, this is like a mild degree of degenerative change. And then finally, we look at the whole body images right here, the left one and the center. And here I'm looking at the joints and soft tissues. Our exams are tailored to give an overall joint assessment, nothing in detail, nothing looking at the ligaments, the labrum, the tendons. It's really more just looking for signs of arthritis, bone marrow edema, swelling, or abnormal joint fluid accumulation. The way that we can do this is I would go like, I can zoom in a bit to get a better visualization. So this is the right shoulder, this is the left shoulder, and what I'm looking for on this set of images is any signs of arthritis, and what I would be looking for are like bony spurs coming off these joints. I don't see that here. And then on this set of images, this is looking at fluid and swelling, and if there is any abnormal fluid surrounding the joint, it would show up as bright white. This is all physiologic. Any bone marrow edema, which is swelling, it would also show up as bright white. And I don't see anything concerning there. Where was I showing? And then right here, I see a little bone cyst within the right shoulder. This is pretty common just from traction at the rotator cuff insertion, but generally benign and nothing to do about that. And then I just do the same thing for every joint, all the large joints, the hips right here. Here's the right hip and here's the left hip. No signs of bony spurs. The joint spaces overall look preserved. No signs of bone swelling or abnormal joint fluid accumulation. Same thing with the knees. I just zoom in again, looking at each knee. Also look pretty darn good here. And then the ankles. The ankles can be pretty challenging for us, depending on how the feet are positioned. But we still give it an evaluation to look for any kind of significant arthritis or swelling going on, and I don't see anything here. And then what I really like about these is looking at the bone marrow itself, which is this right here, looking at the spine and the pelvis to look for any kind of pathologic process that could be abnormally replacing our normal bone marrow. And I don't see anything concerning going on there. And then I do look at the soft tissues to see if there's any masses or any other abnormalities going on. And I didn't see anything on these sets. I did notice these squiggly lines right here within the lower legs on the left. These are varicose veins. These are just dilated veins that people may notice even just on direct visualization. You'll see bulging veins on your skin, and that's what these are. So we can actually see those here. So that's a good example of a varicose vein. All right, I think that takes us to the end of the tour. I did pull up a couple other cases just to show you some other pathology. This one is prostate. Just since I was showing a female, I wanted to show the difference in the male protocol is that we actually obtain a small field of view of the prostate right here. So that's the bladder. And as I scroll down, here's the prostate. And really what we're looking for is we're screening it to look for any kind of signs of inflammation, enlargement, or prostate cancer. The way that the prostate is actually divided up is there's centrally here, this is called the transitional zone. This is the area of the prostate that tends to enlarge in males and cause obstructive symptoms. And then there's the peripheral zone that wraps around it. And this is the most common area that prostate cancers develop. And what you'll see here annotated with these red lines is this really dark rounded area within the peripheral zone on the left side. And that to me is a bit concerning, just looking at that set of images. When I go to my diffusion images, which is some of the driving sequences we use to look for signs of prostate cancer, when I look here, I see it really dark in color on this set of images and bright right here. So this tells me that it's a hypercellular process, a restricting lesion. So this would be concerning for a prostate cancer that does warrant further evaluation and discussion with a specialist, a urologist in this case, where they would look at the blood values and potentially, depending on the whole picture, go for a prostate biopsy to either confirm or exclude prostate cancer. What I can say too is that even if I was thinking this is prostate cancer, I don't see any signs of spread within the lymph nodes or in the bones, which are the two most common areas that we tend to see spread of disease from prostate cancer. Okay, I think that takes us to the end of the tour.
Yeah, this is Andrew coming back on. Wow, wasn't that a cool sort of like zooming through the body? But I wanted to start with a question from one of the other channels, which is about inflammation. What sort of inflammation can we see with these scans? And over to you, Dr. London.
Yeah, so depending on which body section we're looking at, we can see signs of inflammation. Generally, it's those water or those fluid sensitive image sets that detect inflammation really well, and it shows up as really bright signal or color. So we can detect it. It just depends on which part of the body. Sometimes things will manifest that we'll have to give kind of what we would call a differential assessment of what's going on, of the type of process. And sometimes inflammation and cancer can mimic each other, and we don't really know, and it requires further testing to actually distinguish between the two.
Let me dive in on two types of inflammation I guess are quite common.
Yeah.
First would be like RA, so rheumatoid arthritis. And then the second would be like inflammatory bowel conditions. What can you tell us about both those two?
For inflammatory bowel disease, now often it may require a tissue diagnosis to come up with that, but we may see a typical pattern that we can and kind of narrow it down. But on this particular image set, this is the one that detects inflammation and fluid. And so here, take this, for example, this is the large bowel, the colon. And what I'm looking for, if there's any signs of inflammation, I would see wall thickening, so it would get thicker. And it would also get brighter in color. And I may even see, and often do, a bright signal adjacent to the bowel, which is also inflammation that's kind of extended beyond the wall into the tissue adjacent to it. Something that we see a lot of, this particular patient didn't have, is something called diverticulosis. And what that is it's abnormal outpouchings of the colon wall. And what can happen is because the content within the colon is not sterile, we can get impaction in there and bacterial overgrowth and infection. And it's a really common process that happens to us, and it's called diverticulitis. So knowing about the condition itself, diverticulosis, is important just in case you do experience clinical symptoms of diverticulitis. It'll go off in your head, and you'll seek help earlier, which is generally can be pretty conservative therapy if you catch it early enough, antibiotics and some rest.
And you have Crohn's and IBD.
So,
Uh,
so IBD, they're the two main categories there. IBD is the big umbrella term, inflammatory bowel disease, and then there's colitis, ulcerative colitis, and Crohn's disease. Crohn's disease can involve anywhere in the GI tract. Common areas that we see it affected is the distal small bowel, the terminal ileum, and then also the large bowel. The ulcerative colitis involves the large bowel. And if there's any question about which process is going on and to drive therapies, again, GI specialist, gastroenterologist can go in with scopes and take biopsies, and they can look under the microscope to help distinguish between the two.
awesome. Let's go to another question that came in on the other channels. Sort of an interesting one. Can you see parasites or worms on these scans?
I generally I'm going to say no, but there are situations where we can see processes going on that may indicate it. It's not common, particularly in our patient population. There may be parts of the world that actually it's much more common, but I have not personally seen a parasite on our images yet.
Awesome. There are those ones you can get in the brain, I think, in some parts of the world, right?
Yeah, the brain, the liver, would be two great examples right there.
Talk about kidney stones. There was a
Ah,
question that came in on one of the other channels.
Thank you. I meant to talk about that when I was looking at the kidneys. Kidney stones don't show up well on MRI. They just I've seen even sizable kidney stones that I've had two different modalities next to each other, meaning CT and MRI, and it just lights up like a light bulb on the CT, but you cannot see it on the MRI. But what we can see, even if there are stones, what we can see are any signs of obstruction. So even if we don't see the stone, but it's causing obstruction, we are going to see that obstructive process. And this is the kidney. This is the left kidney right here, and this is the pelvis where the fluid gets filtered through and down into the ureters. And stones, if they build up in here and block this the flow, this is going to start to enlarge or dilate. And so that if I saw that, I would probably suggest that this could be a kidney stone that I can't see and recommend an additional test, CT or ultrasound.
Fantastic. Let's see. What other questions do we have here? Do we check for blockages in arteries? So I guess maybe talk a little bit about. I mean, obviously answer the question, but maybe talk a little bit about how we can get a sense of whether the heart is pumping well, and maybe get a sense of like atherosclerotic disease.
Yeah, so MRI, there are techniques that we can do, but they're more dedicated techniques to look at that. Our exam, because in the screening setting here, we cannot see the heart vessels. Like I will never comment on them on this test. I can't even see them really. The larger arteries, like the aorta and the major branch vessels coming off of it, I can see, and there are secondary signs or clues that there could be blockage within these, but and the way that I look for is like what I'm looking for is this black signal within the vessel itself. This is called flow voids, or this is when the blood is moving normally in healthy vessels. There's no signal detected because it's moving so fast, and so it should be black like this. If I saw this now, if I saw this as like bright white, that would be very concerning to me as a potential blockage, and that would be really significant, by the way. But we also have to be very careful because MRI and vessels are prone to artifact, particularly when not using contrast or dedicated techniques like we did in the brain for that MRA. So overall, this test, if you have concerns about your vessels, it's best to do dedicated imaging.
Dedicated CT typically, right?
CT is great because it's quick, and the anatomic detail is exceptional. And then even calcification is picked up really nicely on CT, whereas we have trouble visualizing calcification.
There was a question, maybe I'll have a quick go at answering this, but feel free to clarify, Sean, on the clinical side. So there was
Mhm.
a question just to explain a little more detail the three different scans. So the torso cancer scan is mainly focused on looking for cancer in the torso, which is where something like 90+% of the cancers that we have excluding, let's say, skin cancer, that, where the solid tumors appear. And that's a 15-minute scan. And that one we sell for $1,000. There's a head and torso scan where we add a little bit higher resolution imaging, I believe, in the pelvis, and then we also add the head and neck to that. And then the comprehensive exam also adds the legs, and importantly, we do a detailed spine evaluation as well. Is that a fair assessment? What did I miss?
Yeah, that's pretty accurate. I would say that and then the torso can be a little confusing to people because it's like it's a chest, abdomen, and pelvis. And like you said, I totally agree. The vast majority of cancers that we're probably going to detect are going to be in that area. And so those are the main differences. Yeah.
Best time of the cycle to scan. You mentioned the uterus and the uterine lining is obviously changing. Is there a best time of the cycle to scan? Or if someone comes in for subsequent scans, should they come in at the same time of their cycle? What do you recommend around this?
I really have no strong recommendation with that in that regard. For a premenopausal female, like I expect that endometrium is going to be variable in appearance, and that's okay with me because it's going to, even if it's thick and a little bit heterogeneous in appearance, like I attribute it to the menstrual cycle, unless there were specific symptoms that needed to be evaluated or there were other concerns. I think in like an asymptomatic person who's looking for general screening there's really no strong recommendation there.
And we do ask in our medical history when a woman last menstruated, right? So if
Yeah,
there is,
which is helpful to us because then they can help clue me into what I'm seeing and just say, okay, this is consistent with the reported history, so no concern.
there was a question, I think this is really important, and it also came up in the Q&A. Talk about a dense breast tissue and, how do these scans perform? How do I think about them in the context of, say, mammography and ultrasound? Maybe talk a little bit more about that because that's obviously breast cancer is one of the most common cancers. A lot of people are concerned about this. How does it perform? And, as a radiologist, what do we generally recommend?
Yeah, so there are varying degrees of tissue composition of female breasts. It can be entirely fatty where it looks just bright white. It could be scattered glandular tissue. The glandular tissue is this darker area on the background of the fat. And then you can have heterogeneous looking tissue or really dense tissue, as Andrew was saying. And the denser the tissue, it can start to obscure small masses on all modalities. And then what you're really trying to do is optimize your techniques, even mammography by doing something called tomosynthesis. And then with MRI, adding contrast in there can really help highlight those masses in the background of dense tissue. Now, breast MRI with contrast is not necessarily needed for every person. It's generally reserved for higher risk people or for problem solving. And high risk can be assessed with your doctor. They can do a profile assessment and determine if you're at a higher risk than the average population. But ultimately, I would not say, I wouldn't, I think all modalities complement each other, the imaging techniques, and I still favor all of them in our context because there are
And,
things that I can't see that other ones are going to pick up.
and we do work with a lot of physicians that seem to alternate between these different modalities for breasts, ultrasound, mammography, obviously, and, MRI.
Yeah, and ultrasound's great, particularly when you're doing interventions and everything, and it also there's no radiation. But people at high risk tend to alternate between mammography and then dedicated breast MRI every 6 months.
There's a few lightning round questions I think are pretty easy to answer. Do we cover abdominal aneurysms?
We can see, so we covered the aorta in the sense of we're looking at its size. I know I kind of emphasized the one in the chest, but here I can also see it in the abdomen all the way down. And so I do look at this as well to make sure it's not abnormally dilated or aneurysmal. And so yes, the answer is yes.
What about stroke and TIA occurrences, detection of seizures?
Yes, so we can see stroke. I hope we don't see any acute strokes in our clinic. Those should be going to the ER, but we can see signs of old strokes. The brain that I showed was very normal looking, and I didn't see any signs of old stroke or something that we call white spots, which are commonly attributed to small vessel ischemic changes. So what they'll show up as is bright white spots within the brain tissue. So we could see signs of old stroke or little micro strokes.
Okay, they have. I mean, you joke, but we actually have one or two occurrences where
We
some.
have, yeah. No, yeah, it was kind of like a little bit of a joke, but it was also serious.
Talk a little about. I'm going to sort of reinterpret a question that an anonymous attendee asked. It's about doing a wet read, where we review the images while the patient's still at the facility to determine if we want to redo any images. So, can you talk a little bit about sort of like the training, quality and training of our MRI techs, and how we sort of have a QA process of those images, as the patient is there in the facility.
Our technologists are exceptionally trained and they know what we're looking for, and they know image quality very well. And so what they do is they have autonomy and they repeat sets of images on their own. If they feel like the quality is not good enough, they're going to repeat that image set. Now they can only do it so many times because you can't be in there for too long. You're going to start to heat up too much. But they will give every effort to repeat the images to get the best image quality. And then there are situations where if they see something unusual, they don't hesitate to reach out to their senior technologists and radiologists for basically a wet read of that abnormality to make sure that we don't need further imaging or anything that needs to be done acutely and managed.
And I think for a couple of areas of the body, like the brain, they also do additional sequences if they see something that's concerning.
Yeah,
Uh,
so exactly. If we saw a brain mass or if we saw too many white spots within the brain, we can they will add additional image sets, specifically something called susceptibility weighted imaging, to give us more information and help us characterize the process that's going on. But if they don't see anything, we generally don't add that in at this time.
And then I know when I visit them every so often, they spend quite a bit of time practicing and learning anatomy and sort of helping to understand some of these disease processes. Because one of the things that's a little bit unique is obviously we screen people and then we read those images and then we prepare a report and release it to the patient. And the typical process that we follow is first in, first out. So the image, the next study that Sean would be reading would be sort of like the older study that's in the queue. But the technologists uniquely have the ability to sort of prioritize a reading. So if they see something that is concerning, they put those readings to the front of the queue as well. And that typically means that those are read within 24 hours, often sometimes even within a few hours. And then that's another sort of additional lever that we have to make sure that if we see something concerning, we obviously find a way to get that back to the patient and their care providers as quickly as possible.
Yeah, exactly. And we appreciate that as radiologists to have their set of eyes looking at these things as well. So,
Let's see what other questions we have that are unanswered. Talk a little bit about sort of maybe alternating scans. We talked about the difference between comprehensive and head and torso cancer scan. What are your thoughts about maybe doing a comprehensive, this month, but then following that up with one of the other scans, at a yearly interval, sort of alternate
yeah,
between
I
these.
think, and this is my opinion, I generally feel like the whole body comprehensive exam is a great one to establish as your first exam to get a baseline of the entire body. And then based on medical history and clinical context, and also what we're finding on these exams, you can either follow up with another comprehensive one, or you could even reduce it to the head, torso, or torso. Let's say you don't want to image your spine anymore, and you're like, hey, I'm not worried about it, or my spine's great. I don't really need to track it next year. You can do the head, torso, or the torso exam and do more of an abbreviated version.
There's one sort of really important thing to talk about that some folks are a little confused about on the chat, potentially, which is we don't need a physician referral to do these scans. So what happens is if you're interested in a scan, you can reach out directly and book with, on the website or book with our team. And then we have a medical practitioner who does like an appropriateness review just to make sure that there's not any particular contraindication for an MRI scan. For example, we don't presently scan patients that have pacemakers. But I would say the overwhelming majority, it's high 90 percentile of folks are able to do these scans. There's no contraindication. And then they also do a review for the reason for the scan. So there might be patients that, their primary reason is something that is quite diagnostic. Like they might indicate that the only thing they care about is that they are having these recurring migraines and they want to get some resolution for that. And in those cases, we typically recommend that they go get dedicated imaging. But most importantly, in no cases, if you do a Prenuvo scan, do you need a physician recommendation. If folks don't have a physician, a primary care provider, which is not uncommon, or if they're getting some resistance from their primary care provider about doing the exam.
Yeah, I think you answered it there, that they don't. But I would emphasize that if you have any question or concerns about the appropriateness, or if you want to know more if this would be a good fit for you, always ask. There's no harm in asking, and we're more than happy to answer that.
Awesome. Dr. Gabba asked the question, what's the ideal age for the scan?
Interesting. I've been thinking about that a lot lately because we see such a variety of different ages. We don't scan anybody under 18. 18 and up is our age range. But generally in the 30s and 40s, I think is a good time to start thinking about something like this and establishing a baseline. Um, that's just my thoughts on, current practice right now.
Yeah. There was one person asked a question about, essentially, can I choose which radiologist is going to be reading which exam, or can I pick a location where there is a radiologist I want to have reading the exam? I think the answer there is, I mean, most of our radiologists are sort of qualified across more than one state.
Yeah, we're all board certified, and
Yeah.
multiple of us have multiple licenses. I would like to emphasize too that we are a very collaborative practice, and we consult with each other because a lot of us we have subspecialty training. I did a fellowship in body imaging. Others have done fellowships in musculoskeletal, neuro, breast, pediatrics. And so we really like to take advantage of all of our expertise to provide the most accurate interpretations and best guidelines for management. So I can understand that request, but I do want to reassure people that we do collaborate every day and ask each other for second opinions and additional information.
Some folks, I guess, have asked a definitional question. If we're doing the whole body, why not scan the hands and feet and arms? Can you maybe talk about, I guess, the trade-offs that we have there in terms of time and, yield on the scan?
Yeah, there's nothing free in MRI. You can't have everything, unfortunately. And when you get into the smaller parts of the body, like the hands and the feet, to really get a detailed assessment, you need to do dedicated imaging with dedicated coils. Like we're using body coils with a neck and head coil, whereas these coils are specialized to provide the best signal for interpretation or best image acquisition of those particular areas. So it's just one of the limitations that we have currently with technology.
There's a question. Let me tee this up for you, Sean. There was a question just about around sort of like false positives, false negatives, and so on. So here I'm going to presume that we're talking about cancer and or sort of cancerous lesions. And your radiologist essentially risk stratify the lesions that they see, right? So we have a 5-point classification that we're working towards, and the first 2 points of those are essentially don't worry, they're benign. 4 and 5 is, hey, this is really concerning or increasingly concerning. We, really need to go follow this up. And then there's this sort of category in the middle that's sort of indeterminate. And some of those are maybe indeterminate because they're pretty small, and maybe we would follow them longitudinally. And some might be indeterminate because we need to do additional tests. Is that sort of a fair? So the question of false positive is a little hard one to answer because these tests are not the last test you would get before a cancer diagnosis. It's more about risk stratifying what we're seeing. Is that a
Yeah,
fair sort of
yeah,
summary?
and I do think that's a fair summary and nicely summarized. I think that it's important to understand what we're doing and the context that we're doing it here is that we are screening the entire body essentially, and we are looking for findings. And our bodies produce, cysts and other types of abnormalities, but it doesn't necessarily mean they're actionable. And that using this type of risk stratification system, something called OncoRads, and then one that's been internally developed called clinically significant diagnosis, CSD, we can use that to help kind of lump these findings into certain categories to help, convey what we're trying to say about them and guide management. And the thing too, like when you're getting into the indeterminate category, like 3 that you were talking about, it doesn't necessarily mean that we haven't don't know what it is, but it may not have a typical appearance of a very benign lesion that we're used to seeing, and that we might want to do either a short follow-up or a dedicated image to confirm what we're thinking, because we don't really want to take much chance here. We really want to provide the best care that we can, and provide the most accurate and relevant information from the image that we have.
Yeah, I mean, there's sort of an objection that you sometimes hear, which is these scans are going to result in a whole bunch of people getting biopsies. And I think, we've now done 100,000 of them. There are sometimes biopsies, but I would imagine that's, reasonably rare. And I know you guys looked at it, and I think close to half of all the people actually did get biopsied. Those biopsies came back cancer, which is a pretty high rate.
Yeah, and I think it's really important to use all the information you have and not just act on, a little bit of information. To go from to have like a lesion in our exam go directly to a biopsy, I would suggest don't do that. Get as much more information before you go and start intervening aggressively like that.
Well, for sure, we would never recommend it. I mean, the
No.
recommendation would be do other dedicated imaging.
Yeah,
Um,
and then confirm whether it actually needs to be biopsied or not. But I would never do that straight from our exam.
Okay, I think we got a couple more questions. We're reaching the end. So if you do have a question, now is the right time to put it into the Q&A or raise your hand. Here's an important one. Let's say someone has a metal implant. Now here, I'm mainly talking about things like spinal fusion or, hip replacements or things like this. Can you talk about how that, first of all, is it okay to scan with people that have these types of not uncommon metal implants, and how does that affect the quality of the imaging that we're able to take of those regions where those implants are?
Yeah, these arthroplasties of the implants, like the hips and the knees, I think they're pretty much made of titanium now, which is MRI compatible, and meaning it's safe to scan. But they do cause artifact. Like when I was going through the exam and we were looking in the mouth, there was some dental hardware in there that was causing artifact, and that's very similar to what happens in the hips. And depending on where it's located, so for the hips, it can create artifact and obscure the pelvic organs, so we may not get the best assessment. There are ways to try and mitigate the amount of artifact that's produced, but even with dedicated exams, you're still going to get some artifact.
Excellent. And just I want to like reiterate because it's quite a common question. If you have dental work, you can still get a scan, correct?
Yes, 100%. Yes.
Otherwise, otherwise there wouldn't be too many people getting scanned, I don't think.
Lots of us have dental work and we get scanned.
Let me ask someone asked a question about like expected wait time for clinics that are opening soon. Let me answer this one.
Okay.
So the next clinic that's opening is Vegas. We have a few others that are opening in the coming months, and we have wait lists for all of these clinics. And what we tend to do is we reach out to people on the wait list before we open up to the general public. So the best way to be, one of the first people in the door is to make sure that you go to, I believe it's prenuvo.com/locations, or there should be a link for locations at the bottom of the page. And you'll see the locations that we have coming soon. And, feel free to add your name to that wait list, and we reach out before we open it up to others. Let us see. I think we've gone through most everything. Yeah, I hope people love the webinar. I always think it's fascinating the questions that come up, and we do these every few months. So if you are still on the fence and want to learn more, you're welcome to come back for another one of these webinars, and feel free to also tell other people about what we're doing, and there'll be a webinar that they can then attend themselves. The goal here of the company is to change healthcare from reactive to proactive. Core value of the company is to provide a very high quality clinical exam and in-clinic experience. We want you to have a great experience, so you tell family, friends, colleagues, and people on the streets about what we believe is an incredible test. And I look forward to and hopefully seeing you in one of our clinics soon. Thank you very much, everyone. Thanks again, Dr. Sean London. Take care, everyone.